everyone. I would like to thank everyone to logging in to our Wellness Wednesday live webinar. This is a platform focused on health and wellness with guest speakers and specialists answering your questions about physical and mental well-being. My name is Zarmina, and I'm delighted to be on this journey with you today. For today's session, do remember you may submit your questions through the chat feature on this platform, and we will get to them in the second half of this episode. A little bit about our speakers today. We have Dr. Donatella, who is currently working at the Valiant Clinic in Dubai. She is a specialist in endocrinology and diabetes. She has developed an extensive experience in diabetic care in the past 25 years and has a particular interest in education and community care. Thank you so much for being with us, Dr. Donatella.
Thank you, Zarmina, for inviting me. Hi.
Hi. We have our second speaker, Mr. Abdulrahman Attili. He is a health economist and a diabetes expert in Central Eastern Europe, Middle East, and Africa region for the last 10 years. Mr. Abdulrahman has a special focus on glucose monitoring, continuous glucose monitoring, and diabetes care. Hello, Abdulrahman. How are you?
Hi, Thelma. Thank you very much. And good afternoon, everyone.
Thank you. And last but not least, we have Dr. Noaman. Dr. Noaman Sanni is an ophthalmologist in New York and is affiliated with multiple hospitals. He has been in practice for over 30 years and was one of the first surgeons performing LASIK and Intacs in the Syracuse and Watertown areas. Thank you, Dr. Noaman, for being here today.
Glad to be here.
So lovely to have you all on this webinar. This is a big topic. We have a lot to unpack. So I would love to jump straight into our first question. As you all know, this is a diabetes special for this episode. So starting with Dr. Donatella, I would love to ask you, when it comes to diabetes, we often hear there are multidisciplinary care teams when it comes to treating a patient. What does that mean, and why is it necessary to look at this in a multidisciplinary approach?
Okay, so we try to define diabetes like a chronic condition that tend to deteriorate and require multidisciplinary approach. So I'm going to try to explain what this big word means. So chronic condition usually refers to some disease that tend to last for life. So it's a life condition that can improve, but it is, most of the time it's a condition where people need to deal with them for life. So it's a chronic condition that deteriorate, so tend to get worse by time. So this means that at the beginning of the disease, a patient with type 2 diabetes can just be managed easily in a way where they need just the caring physician, can be the specialist, can be the general practitioner, need a dietitian, and need an ophthalmologist, because at the beginning of the disease, they need to address a few of the aspects of the condition, which is usually how to manage and maintain a good blood glucose control, be sure they don't have complication. But unfortunately, by time, type 2 diabetes is associated with long-term complication. Long-term complication means, in few words, that diabetes is associated with damage of multi-organs. So it's associated with, we call diabetes retinopathy, and my colleagues, I'm sure, will explain you in deep what does it mean. It's associated with damage in the kidneys, increased risk of heart attack, and can affect nerves. So when this organ start to be damaged, become another disease. So it means that by the time a patient with diabetes that develop multi-organ condition may need different specialists that will be able to deal with different aspects of the complication of the disease. So at the end, a patient with long-standing diabetes and complication may need to have the treating physician, that can be a specialist usually, may need an ophthalmologist, a nephrologist, a cardiologist, always a nutritionist, a neurologist, and more according to the complication developed. So it's a complex condition. And so this means require multidisciplinary approach.
Absolutely. And speaking of the multidisciplinary teams and the importance, of that when it comes to diabetic care, Dr. Noaman, can I ask you, can you tell us a little bit about the points that Dr. Donatella mentioned and about diabetic eye diseases in general and the potential risk if it comes to the negligence of eye health, which may happen from time to time?
Yeah, I mean, it is. I think the advantage that the ophthalmologists have is in diagnosing actually diabetes through exams, which especially in the third world region of the world gets missed. And I think a lot of time, the first time the diabetes is picked up as in the eye doctors during the eye doctor's exam. And as we know that in the next 10 years or so, there'll be over 200 million people with diabetes-related eye diseases. And that's a huge number considering like only 10 years ago, the number was almost half or so. So there are different stages. And as you know, the diabetes can affect every part of the eye, right from the surface. It can give you dry eye syndromes. It can cause strokes of small blood vessels, which can give you double vision and difficulty in moving the eyes together. It can create cataracts, as we all know. They're called posterior subcapsular cataracts. And then, of course, the most damaging thing is the retinopathy, or the damage to the retina, which is basically the film of the camera, where all the visual information goes from your eye to the brain for you to see. And what happens in diabetes is that there are two ways that the diabetes damages the back of the eye. One is because of just leakage of the small blood vessels. And second is by blocking the small blood vessels, either by inflammation or other factors. And so it may take a few years for the first signs to develop. So by the time an ophthalmologist sees a patient who has any appreciable eye disease, then you already know that the patient has had diabetes for over 7 to 10 years. And then there are different stages of diabetic retinopathy. And untreated, it can definitely cause blindness. And there are millions of people every year that go blind because the diabetes wasn't diagnosed. And they usually ask for intervention when the disease is pretty late. So in the initial stages, sorry, yeah.
No, please go ahead.
Okay. So in the initial stages, you just see small microaneurysms, which are just small little outpoachings of the blood vessels. And in the advanced stages, you'll see full-fledged hemorrhaging in the back of the eye, retinal detachments. And also in diabetes, as you know, there's an element of neurodegeneration, where it affects the retina that way and delays the visual transformation. And also it can damage the nerve, which is, as you must have seen, acute papillitis, where it can cause permanent damage to the vision.
And Dr. Noaman, you touched upon such a great point that it can take a lot of time to progress. So what could be done during this progression stage? What are things that people can look out for to avoid falling in the category? Like you said, they may have had diabetes for 7 years and now they have a
You should immediately call Dr. Donatella, because I think the diabetes, the control of blood sugar is paramount, right? And there are a lot of studies that have shown that if you control the blood sugar and hemoglobin A1C, there's a direct relationship with reducing A1C by 1%, which cuts down the retinopathy by like upwards of 10-20%. So I think early diagnosis and strict control is extremely important, and you can really delay the lifelong devastating changes by having Donatella involved, right? Or endocrinologists and primary care people.
Yeah.
Thank you, Dr. Noaman. That's so timely, and being at the end of the Diabetes Awareness Month, it's a great message to reiterate, being aware of one's blood glucose levels and taking that proactive approach. I would like to kind of to Abdulrahman, you work closely with pharmaceuticals, medical devices. You're deeply knowledgeable in market research and market behavior. But I really would like to know from you, what is the link between pharmacological and non-pharmacological approaches to the management of diabetes patients?
Yeah, usually with all diabetic patients, and you are talking about like type 2 or type 1, there is a pharmacological approach designed for such patients population. And this is usually coming from the societies like ADA as a guidelines. So if I want to give some focus on type 2, as Dr. Dantella said, that this is a progression disease. Usually it will start with less issues, but it will progress and the cases will deteriorate with time. So usually from pharmacological approach, they will start with one oral medication. It will add up with a combined oral medication. Then at the end, the patient will reach to be insulinized. And from insulinization perspective also, they can reach to what is called multiple daily insulin injection. And here is, whatever medications we are talking about, either oral anti-diabetic agents, or even to reach to the insulin. And again, in the insulin, we have a lot of insulin available, like long-acting, the premix, long-acting, or what is called basal bolus. The objective is to delay the progress of this disease, to try to delay the complications, especially with type 2. Usually the patient will be diagnosed as type 2 after quite good number of years, where he will already started building these complications. So this is from pharmacological approach. From non-pharmacological approach, which is very important also to augment the non-pharmacological approach here about glucose monitoring, about the nutritionist, all of this to help the pharmacological approach to reach to the A1C that was mentioned by Dr. Noaman. And now the things are moving from A1C to time in range, because from pharmacological aspect, usually there are 3 clinical outcomes. First of all, to avoid hyperglycemia, to decrease or minimize the variability, because usually the glucose is fluctuating, especially with the disease progression. And here is very much associated with a lot of complications, and also to avoid hypoglycemia. So that's why now we are talking about how we can reach to a flat, narrow profile of these patients. Now for type 1, definitely the pharmacological approach is totally different, because type 1, they have 0 insulin, so they have to start with insulin from day 1. But from the non-pharmacological approach, in a way, I cannot say they are similar to type 2, but glucose monitoring is very much needed. That's why the guidelines for glucose monitoring is much highly recommended in terms of numbers to check their glucose for type 1. So the more the patient is in insulin, the non-pharmacological approach became much more important, because we need to treat the patient not in a blind way. We have to see how is the glucose is behaving, and also we need the patient to be part from the decision, because now the dialogue is very important. The patient has to be a part from the equation, and here is the CGM is very important. I hope I answered the question in like just tackling both type 1 and type 2.
Yes, thank you for that. You've touched upon such key points, largely patient education, and we see so much material out there. And we've also worked with Dr. Donatella on a series that's focused on so many of the key points. How to take the insulin and hypoglycemia. So, Dr. Donatella, I'd love to ask you in response to, or in addition to Abdulrahman's response to that, you've been working on the same with patient education for type 1 and type 2. What would you like to share?
So, as you know, I'm a big fan of education. So education for me means, first of all, to make patient aware about the disease. So to give the right message so the patient can understand. The second message I give to the patient is they are the responsible of their disease. Many patients, they do not accept the disease. And one of the big issues we have is the inability or lack to reach the target that we agree with the patient. And this is because patients are not engaged in the management of the disease. So engagement, information, and responsibility are extremely important from the beginning of the disease, which I consider even pre-diabetes stage. So when the patient is aware and start to be responsible, he will be able to respond better to our advice. And I always invite them to be protagonists of their own condition, to gather information, to understand when they go to do the shopping, what they are going to buy, what kind of food. So education starts from the beginning, the very beginning, and include every aspect of their lifestyle and management. So this is the first step. Engagement is very important. If you give this right message from the beginning to the patient and they start to be engaged, you can have amazing results. I just wanted to tell you the story of one patient I recently saw that attended to my clinic with a very high HbA1c at the beginning of the disease. It was more than 11. So of course, it was a kind of a situation where you can't not give medication because his blood glucose is quite high. And so I start him of some medication, but he was enthusiastic about the idea to wear a continuous glucose monitor. Although he didn't start on insulin, he started to wear, and of course we just discussed about how to manage or monitor diabetes, a continuous glucose monitor. And I didn't tell him anything because, of course, I'm not going to be so aggressive with the management. But what he did on his own, he started to diet and according to the level of the blood glucose. And after a month, his blood glucose was totally in the normal range. So totally in the normal range means he didn't have even any excursion above the 140 of blood glucose, which is usually considered, abnormal. This was amazing because he's really get the message. And my only concern is that he will, feel tired to do that and stop and go back to I was before, because this is one of the problems. It's not difficult to achieve some results at the beginning, but because it requires a lot of effort, a lot of commitment, patients often give up and they start to go back to old habit and they lose all the benefit. But this is just to tell you how an engagement of a patient that was already presenting with a quite advanced disease actually bring him to a normalization of the blood sugar. So now it stayed on him really to be able to continue with this kind of change and continues to have a normal blood glucose. So the first message is, okay, so we can improve quite a lot, even at the first presentation with very high blood glucose. So this is a positive message. So something that need to encourage, give encouragement to patients that say, okay, you can do it. But then is to embrace the disease. Do not deny the disease, because more you know from the A to Z, more you can be in charge of the disease, and don't let the disease be in charge of your life. So this is a very extremely important. So personally, I used to spend much more time with patients at the beginning of the disease because I wanted really them to give the message that they can make a big change and really change their future quite a lot, and give them the instrument of how to go through this and achieve the results. So education and awareness and power, give the power of the patient is a very important goal to achieve. Of course, there's a lot of work there. It's not something that is achievable in a short period of time, but also the patient need to understand that is not a short journey they are going to have.
That's such a remarkable story of your patient that you've shared. And I think it really shows that it's not about being given instructions and guidelines, but rather about understanding it and which motivates you to take those steps. But how would you say that knowledge is linked to a long-term ability to self-manage?
The knowledge. Okay, so there are, of course, we are going to do a kind of a wide discussion, but we usually give a kind of a quite precise target to our patient. So, and the target that regard how to manage the blood glucose and with target to achieve in terms of diabetes control. Not only this, because I usually divide in three different approach. One is management of the blood glucose. One is a screening of the complication. So complications are silent. Unfortunately, they don't give any sign unless it's too late. So we have to find out. We have to put in place a system for what periodically our patients are screened for retinopathy, nephropathy, neuropathy, all the diabetic complications. And I tell them, look, living in Dubai, of course, people come and go. I say that even if you are not here with me, keep in mind, you are the one who have to remind yourself that you have to do this check at least once a year. Don't put your responsibility to somebody else. This is your duty. To make this responsibility, they will be the one who remember they have to do this check. And then once you find, for example, some abnormality in their blood, it can be the cholesterol, can be the blood pressure, then you start the treatment. At a certain point, as I mentioned before, the complication can be more advanced. In this case, of course, we need the support of other specialists because become too advanced to be treated in not a specialist setting. So it's a complex condition. They require multiple care, multidisciplinary approach, technologies, and other help.
Absolutely. Dr. Noaman, I'd love to pull you in at that point, speaking particularly of diabetic retinopathy. What does that mean exactly? And what are the typical progressions for an individual with diabetes regarding their eyesight? And how would you loop that in with your patient when it comes to the knowledge and, to self-manage and to take preventative steps?
Yeah. Well, thank you, Dr. Donatello. That was a good synopsis. And I agree that it's a disease that's caused when you mismanage life, right? So I think you need to manage, the challenge is how do you manage a lifestyle? I think you have to manage the entire lifestyle to treat this disease. And unless the patient is a partner, it's extremely difficult because they're in the doctor's office only 20 minutes, an hour, and the rest of 23 hours, they're binging on food or sitting on a couch. Or, sometimes the things are more complicated than that. So we have to manage their lifestyle. I think that is the key, as Dr. Donatella was saying. As far as the eyes are concerned, ideally anybody that gets diagnosed by the primary care with diabetes has to have a baseline exam, because it doesn't necessarily mean that when they were diagnosed is when they develop diabetes. Because sometimes when we screen patients, they already have had signs of diabetic retinopathy, which typically would take at least 7 to 10 years. So, and the moment we see any signs, the first signs, the early diabetic retinopathy, it's okay to just observe them every 3 to 6 months, unless they have some risk factors and their hemoglobin A1C is through the roof, and they have visual issues, because your vision fluctuates with fluctuating blood sugar levels, because the cataract swells, your lens inside the eye swells and shrinks based on your sugar levels. So as long as it's mild retinopathy, which is just a few areas involved, we can safely see them 3 to 6 months. But as the disease progresses, there is leakage right in the central part of the eye. When we see that, and then fortunately, now we can just inject some drugs which are called anti-VEGF, which suppress the leakage of the fluids, and they suppress new blood vessels growing. Because before these drugs, the only treatment we had was laser treatment for the central part of the eye, which was more destructive and not quite as effective as some of these new injections that we place right in the eye. It takes a second, it's easily tolerable, and Then we have a series of injections that we give, about 5 or 6 injections a month apart or so, based depending on what medicine we are using, as there are 3 or 4 different medicines that we can inject in the eye. So, and usually we can manage it. But again, we need more medications that are under study right now, because this medicine alone, which are called anti-VEGF class of drugs, is not enough. And that's why people should never rely on the medication, but a lifestyle change. So we do that, and if they progress to what we call proliferative diabetic retinopathy, proliferative means there's a proliferation of abnormal blood vessels. The difference between normal blood vessels and abnormal blood vessels is that the abnormal blood vessels leak. The blood vessel walls are very permeable. They leak fluid and they hemorrhage. And over time, what happens is, because of hemorrhage, there is scarring. And when the scarring occurs, it pulls the retina, which is the layer of the eye that gives you vision. It causes retinal detachment. So when we see that the patient is getting towards the proliferative stage, then at that point, we are very aggressive and we do retinal laser, which basically throughout the eyeball. We go and do the laser. With the laser, what happens is, with the destruction of the laser of the retinal tissue, the stimulus for new blood vessel goes down. We don't release any vascular growth factors. So, and that way we can prevent further destruction and formation of new blood vessels. But all those interventions are very timely, because even in the early part, when there's leakage, the longer the leakage stays, the more permanent that state becomes. So it has to be brought to the patient's attention and then treated accordingly. And a lot of the end-stage proliferative diabetic retinopathy sequelae could be prevented if blood sugar is managed and the treatment is initiated at an appropriate time.
Thank you. Absolutely. I think you've hit the nail on the head. The timely intervention is absolutely everything. And also on the point of monitoring, I would love to just, focus a little bit on continuous glucose monitoring. There is a lot of information out there, but in particular, Abdulrahman, I would love to ask you, can you share with us the benefit of continuous glucose monitoring? And I can actually see some questions coming in about that. So we will get to the Q&A in just a minute, but if you could share a little bit about that with us.
Yeah. Was the question to me or to Dr.
Is whoever is ready to jump in.
I think yeah. No,
for the CGM, especially in the last few years, became very, very important. So just confirming to what the doctors were mentioning, the patient is a very important element in the equation. Whatever medication you have, whatever technology you have, all of this is to engage the patient in the equation of diabetes care or diabetes management. He has to be part, or she has to be part from this decision, taking the medication in the right time. So the glucose monitoring is one of the elements which is very important. It started with the glucometers, the strip, which is very much appreciated and covered. But now the CGM became, especially for type 1 and type 2 who are like on insulin, it became a standard of care. If I want to focus on type 2, especially the patients who are receiving insulin, it's an eye-opener for them. The CGM, it's like a movie where the patient can see what's happening, what is his behaviors, what is the food impact on each patient, because the food impact, it varies from one patient to another, even from pharmacokinetics. The CGM also for the clinicians, and I think the doctors, they can say like a lot of oral anti-diabetic agents are available, but what is the efficacy? Previously, it was proven to show the efficacy for any medication through some readings. Now the CGM is much better because it will show a continuous readings where the efficacy of any medication, it will be shown. The CGM definitely it's very important. The more the patient is receiving insulin, he should be on CGM. So like when I want to talk about type 2, definitely it's very important these patients to put the CGM, because when we are talking about A1C, which is, as it was mentioned previously, it is a surrogate point. It's very much associated with a lot of long-term complications. But the CGM will make these complications to be delayed. So the more the area, the engagement of the patient, the treatment will be better, the A1C will be better, all of these complications will be delayed. And the patient has to understand, and usually they are understanding this, that this disease, it's a disease, but we can live with. If you are able to control it, you can live without any complications. And now also from a health economic perspective, it's crystal clear now. We are seeing a lot of, and this is what we are talking about as a health economist, with government, with insurance companies, that maybe there will be some kind of short-term extra cost, but down the stream cost saving, especially using this technology, it's proven now that it is very much cost effective. That's why it's very much recommended for all diabetic patients to use the CGM. Definitely, it varies from population to population, but even for the pre-diabetic patients, it can be good to have it maybe once per year, more for some patients also for therapy titration, to have it like every 3 months or 6 months to do the therapy optimization in the right way. The patient will know how is his eating, how is his exercising, it will be, I'm telling you, it's a magic. When the patient will look to, he will identify that this time I drank orange juice, which does for me the spike. He will see the bread effect during this CGM. Also, the clinician, they will see also the efficacy of the medication. Shall we like go for X category from medication? Shall we increase the doses, or shall we shift to another group? So it's really the CGM. It has a lot of benefits for the clinician and for the patients at the end to get the best diabetes care outcome.
Yeah, if I can add something, Zarmina, I agree absolutely. I think that unfortunately it's not yet used as widely because of the cost of GC, continuous glucose monitor. But I think that if you use properly and you can interpret the results, you can teach the patient how to read it, is a very valuable tool that help patient with diabetes to achieve better diabetes control and improvement and reduce complication. Unfortunately, we don't have many long-term study on a patient with type 2 diabetes not on insulin about this. But if you look at the even very short-term study, if you look at how to use properly, I can see that there is a lot of information and advantage to use this kind of tools in support of diabetes care. So I agree.
Thank you for adding that, Dr. Donatella. I would love to jump into our live Q&A. We have some questions coming in, so I will read them out, and whoever would like to add a response, please feel free to jump in. So one of our viewers is asking, how can you manage and reduce pre-diabetes for the significant population that is diagnosed pre-diabetic? How could we ask that?
I think this is mine. Okay. Yeah. First of all, as I mentioned, I sometimes spend more time with patients with pre-diabetes than patients with advanced diabetes. And the reason is because there is a lot to do with these patients, because if I have to say something to a patient is try to avoid to get diabetes. This is the first message. Usually lifestyle management with a controlled diet weight loss if it's necessary. Usually in patients with overweight or obesity, we advise 10-15% of body weight reduction, and this can be achieved with the help of nutritionist and physical activity. Physical activity is advised to have at least 30 minutes of physical activity, or 150 minutes per week. They can go from walking to more intensive physical activity according to the possibility of a patient can do. So this is the first step. Of course, if the disease in patients with pre-diabetes progress, we can start to use medication at this stage, even if diabetes is not yet has not been yet diagnosed. So the medication which is currently used is metformin, and metformin is used because it's been shown in clinical trials, long-term clinical trials, that can prevent the disease. So first step, weight loss, change in diet, physical activity. If the disease tend to progress, start on metformin.
Great, thank you so much. Let's move on to our next question. How do I know if I am at risk of diabetic retinopathy, and can the damage be reversed?
I think one of the symptoms of significant disease is that your vision will start to fluctuate or will get blurry. That's the most ominous sign. And reversible depends on what part of the eye has the diabetes affected. So if it's just causing significant dry eye syndrome and it is just the surface of the cornea is affected, yes, that could be easily treated with artificial tears. We can add certain medications like cyclosporin, Xiidra. We can put tiny plugs in your tear ducts, and that can alleviate that, because if the surface of the eye is dry, it'll make your vision fluctuate. Okay, now if the cause of the blurriness is the cataract that you have developed, that too is reversible, but that means it has to be removed and replaced with an artificial lens. Now, if the blurriness is from the swelling in the back of your eye, which is the retina, if the swelling is early and is mild, sometimes even mild to moderate, like I had mentioned, we can inject these medications, which are called anti-VEGF medications. It's a tiny, tiny injection that goes inside, the medication is placed inside the eye, and that can help reduce the swelling and reverse the vision loss in a lot of people. Again, the longer it stays, the reversibility is hampered. But if you have significant disease, yes, some of the significant disease can be reversed and some of your symptoms can be reversed. But in really severe diseases, it's difficult to reverse the entire damage that has occurred over 10, 15, 20 years. So again, the main thing is to treat and diagnose it early, manage diabetes as early as possible, and to bring about the lifestyle changes. And I think, knowing your blood glucose level all the time would be a great way for self-motivation and lifestyle management. But yes, some are reversible, but in advanced stages, it is difficult to reverse the entire loss.
Wonderful. Thank you so much, Dr. Noaman. We'll move on to our next question. How do I know if I am at risk for gestational diabetes during my pregnancy? I am not yet pregnant, but I would like to be in the near future. Are there any preventative steps that I can take?
Yes. Okay. So first of all, it's important to look at the family history, because if there is a family history for gestational diabetes, so if your mom had gestational diabetes, or family history for diabetes, obesity, some ethnical have more risk of it in diabetes, like Southeast Asian, they have more risk of it in diabetes. Patients with polycystic ovary syndrome have more risk of having diabetes. So there is a long category of patients or people that might have more risk of having diabetes. So in this case, ideally will be just to have a blood sugar check before get pregnant. So this will be useful. However, if you get pregnant, usually in majority of places like United States, even here in Dubai, they do something called universal screening. So they do a glucose tolerance test between 24 to 28 weeks of gestation, and this will definitely make a diagnosis of gestational diabetes if is the case. So prevention can be done as the same. Try to keep your body weight normal with a good diet, healthy lifestyle. So physical activity, good diet, do not get overweight or even worse, obese. And that's it. This is the best way.
Thank you, Dr. Donatella. Our next viewer is asking, is continuous glucose monitoring effective for pre-diabetes or type 2 diabetes? Could you elaborate, Abdulrahman?
Yeah, as Dr. Donatella said, that the CGM is proven to be very effective for type 1 and type 2 who are on insulin. But also I'm seeing a lot of trials are happening right now, showing also for pre-diabetic and also for patients who are on oral medications that the CGM, definitely it will not be on a continuous way, but in an intermittent way. So such patients can use it once per year or twice per year. It depends. It varies from one individual to another. But definitely there is a value for the CGM for the patients because it will give the patient an idea how is the physiology of that patient, how is the patient is reacting with the food, and also when the patient will start with any medication, it's really a great tool to see the efficacy of such medication, the variability, because one of the most challenging from diabetes management perspective is the variability. And here we are talking about when the glucose is moving up and down, and this is really very difficult. And here is also, part from this kind of oscillation, very much associated with the complications that we are seeing, especially the microvascular complications. So again, CGM, it will be a great tool for all type of diabetic patients, even for pre-diabetic. The value, it varies, but there is a value for sure.
Absolutely. Thank you. And I think, Abdulrahman, maybe we can add for the viewer who asked the question about gestational diabetes that CGM may also be relevant to that as well.
It's very much relevant because even there is a study now, its name is Concept. It was proven that, on the mother and on the baby, the outcome was clinically meaningful. That's why recently in the UK, the NICE guidelines is covering the CGM for gestational diabetes because it was very cost effective. I cannot remember exactly the amount of the money in terms of saving, especially for the babies, because they found the admission or the incubation of these infants after delivery was significantly better who are on CGM while the patients who are non-CGM. So definitely this kind of patients will benefit a lot.
I would also add that I think there are a lot of patients that the doctors put on corticosteroids is a class of drugs that a lot of patients are put on, and we always worry what it is doing to the blood sugar level. And that's another subset of patients that CGM could be considered. That was just a...
Absolutely. Thank you for that. That's very, very important and very relevant. Let's take our next question. What are good travel foods for people with diabetes? Perhaps not too much travel going on, but I think it's a great question, maybe for a long drive.
Yeah, I mean, one of the most difficult things for patients with diabetes is those who travel. So, I mean, some people have to travel for work. And I found that they're struggling a lot to maintain the blood glucose control, because when they travel, not always they found the food that helping there to achieve good control, or they often are tired and they cannot focus on their diet. So it is not easy. So they should, in theory, continues to follow what they have learned about diet. To me, the problem is, if the patient has a very good education, so means knows the food, know how to choose the food, they will have less problem to travel and always find the food they know is okay for their disease. The problem is when they are not aware about this, and then this is when they cannot control the blood glucose during traveling. So I'm not sure what the question means, if they are doing 1 day journey or what is means when they are on holiday, but it should not change a lot compared to what they do at home. They still need to have a healthy diet. Keep in mind what means a healthy plate full of vegetables, reduce starchy carbs, still have some carbs, and all the stuff they learn when they go to see the dietitian, at the beginning of the disease.
Wonderful, thank you. We are actually getting a couple of questions, and I'll sum them into one about stress and the impact of stress on blood sugar levels. Is there an impact, and overall, does it affect diabetes?
Okay, so there are two things to consider. Usually stress is a moment where people cannot focus. So definitely patients who are stressed or busy doing other things will be less able to focus on the management of the disease, which we understand this evening is not easy. Require constant commitment in taking medication, food choice, exercise, and all the stuff we discuss. So patients who are stressed will dedicate less time to treat the disease properly. So this is one thing. So to me, patients who are stressed get poor diabetes control more because they give up on their disease for a while because busy with stress. Then there is acute stress. So we see that during acute stress, and I mean acute means a car accident, a myocardial infarction, so really big event, yes, the blood glucose can goes up. But when you talk about chronic stress, I think the problem is really lack of management.
Great, thank you so much. And another one for you, Dr. Donatella. Can menopause or the menstrual cycle affect glucose levels?
Yeah, we see this mainly in young women with type 1 diabetes, where some of them, not all, but they know where the menstrual cycle is coming because the insulin requirement increased quite a lot. So, and so they struggling to manage their blood glucose during the period before the menstrual cycle or even during the menstrual cycle. So this definitely happened. Patient with type 2 diabetes, this is less common than happen. And the other side, menopause. Menopause is a difficult period because menopause, a lot of change happen. Patients tend to put on weight, may not feel well because of the symptom associated with menopause. So I'm not sure, and I don't think there is a direct effect of menopause, but I think that how menopause affects the entire individual can affect the diabetes control.
Thank you. Well, our time is almost coming to an end. So what I would like to do is take one last question and address it to each of you individually before we close the session. So the last question we will take is, how do I learn to accept my diabetes?
Well, first of all, I think one has to surrender. You can't fight it. And it is a thing that we have to live with, and we manage our lifestyle. And I think people should have the eye on the prize. They will feel good if they manage. It's not only that when they treat diabetes, they're just treating their blood sugar. I mean, they're treating their entire body and how they feel. So I think it should be some positive reinforcement. And I think people should think of it's a manageable disease, and it's by managing diabetes, they'll probably get in the best shape of their lives they've ever thought of. So I think it's self-motivation and not losing hope.
Thank you. That was wonderful.
Yeah, I totally agree. I try to give the patient the glass half full rather than the opposite. And I tell them, you know, sometimes patients with diabetes who are doing the right things are healthier than patients with no diabetes, as you say. First, because they do the right things, they take care of them, they do physical activity, and they go to see the doctor quite often, compared to other people that never see a doctor. So if you put in this perspective and you really give them positive thought rather than give, sometimes I have to scare a little bit those who don't want to embrace the condition, but I try to be positive and give them the right message that if they do the right things, they are going to live a long, healthy life.
Thank you, Dr.
Yeah, indeed. So live friendly with this disease that's why I prefer all the time diabetes care rather than diabetes management. It's about caring. So yeah, it's a disease, but the patient has to understand it and has to live with it in a friendly way.
Thank you so much. Well, thank you again to all our speakers. It was such a pleasure speaking to you today and having you all here together. I think we should do many more sessions because we have many questions coming in. So we have a lot of questions to answer and topics to touch upon. But thank you again for being with us today. And I'd also like to thank everyone who logged in, submitted their questions, and stayed with us throughout this episode on this particular diabetes special that we're having. We hope you gained some interesting insight from today's discussion, and I look forward to seeing you at the next Wellness Wednesday webinar. Thank you. Thank you, Dr.
Thank you very much.
Thank you,
Thank you
Zarmina.
very much.
Bye.
Thank you, everyone. Bye-bye.
Bye.
Have a nice evening. Bye-bye.
You too. Bye.